Right, well, thank you so much to the organizers for having me. It's such a delight to be here with you all, and I am sorry that I missed this morning. I am on service for the EP service, so I had to round and all that sort of thing. I don't think we have any patients with heterotaxy right now in our service, but so I'll be talking about two topics today. I'm going to start with some of the electrophysiology that we see in patients with heterotaxy, and then move on to the intraoperative mapping that Dr. Hoganson alluded to, part of the work that we've been doing. So kind of two separate things that tie together, and I don't know how many electrophysiologists are in the room, but I tried to keep this relatively minimal on the intracardiac tracings because it is, sort of coffee o'clock, but we'll try to keep it as entertaining as possible. So just to anchor us a little bit in some clinical care, I wanted to start with a couple different examples of patients with heterotaxy that have sort of different sides of the EP coin, you might say. One is this patient who is a 7-year-old. He came to our hospital for a consideration for a biventricular repair, actually. He had been palliated down to a Fontan, which had not gone well from a circulation standpoint and had to be taken down. And he came to us with a history of SVT that had been difficult to manage and had at times postoperatively contributed to his poor status. We knew that he had heterotaxy with an asplenius subtype, and we had suspicions that this might have been an AVNRT type or a twin node tachycardia type presentation. We brought him to the lab, where in fact we did confirm that there were 2 nodes that we could map out. One is in that yellow cluster down below. That was where we thought the dominant conduction was going through. But then the cluster in the center of the sort of rainbow is where we mapped out the retrograde conduction of this tachycardia. And what was interesting and is so typically humbling of taking care of patients with heterotaxy, especially when you bring them to the EP lab, is that we found one circuit that we called AVNRT number 1, and whenever you have a number in front of the or behind the tachycardia, it tends to suggest that there's excitement to come, and indeed we had one, then we had another one, then we had another one, and then we had a 4th one. So he certainly did have a history of SVT, and all of it was really very easy to induce, and we'll go into a little bit why you could have so many different things that are all kind of related later on. And because of the burden of the SVT that he had, and sort of how impactful that had been postoperatively, we ended up ablating the sort of weaker of the 2 AV nodes for fear that this would be another issue postoperatively. And unfortunately, in the operating room, the other node was damaged, and so he ended up with a pacemaker. So we'll talk about how that informs kind of how we approach these patients as we go forward here today. On the other side of the spectrum, this is now a 14-year-old young man who has heterotaxy with a polysplenia or left atrial isomerism variant, who had a partial AV canal defect that was repaired in infancy, and then also has even more sort of clinically relevant for him right after birth was that he had both congenital AV block and sinus node dysfunction, to the point that he needed a pacemaker implanted in the neonatal period, and then subsequently had his repair done at that time as well. And he came into us earlier this year having had one of his epicardial leads break, and then was transitioned over to a transvenous system. One of the things that was interesting about him is in EP in general right now, when we try to put transvenous systems in, we're always trying for a conduction system type pacing setup, where we're trying to get into the conduction system to facilitate what we think will be the most efficient way of pacing these hearts. And I spent a long time trying to get into the correct location for the conduction system and wasn't able to, which is why the ECG still looks a little bit wide. But I think this raises more questions about kind of how we can best serve these patients who are on kind of that other side and more prone to the bradycardia than the tachycardia. So let's look at the arrhythmias that we sort of anticipate or know can exist in this group of patients overall. So this is a single report from Texas Children's that was published in 2018 with their single center data of patients with heterotaxy. And you can see that a substantial portion of patients do have either bradycardia that's clinically relevant or tachycardia. and some also have both. It's relevant to note that they also found in this study that the presence of having had a history of tachyarrhythmia increased your risk of needing a transplant, which may be an indicator of other things, but certainly suggests the sort of importance of this clinical significance of that. I'm going to start now by sort of going through the various anatomical abnormalities or differences that we can see in patients with heterotaxy and their various subtypes, sort of marching through the conduction system. The sinus node, I think, arguably is probably the clinically tends to be a little bit less relevant than the AV nodal conduction abnormalities. The main thing that we'll see is while we normally, in a normal heart, we expect to see the sinus node in the upper part of the right atrium near the SVC. In mirror image, we often will just have that flipped, as you might expect. In right atrial isomerism, we often will be able to see, if not clinically, but pathologically, when you look in the pathology lab, you can often identify two sinus nodes that, if they're a bilateral vena cava, sit near the entrance into the atria of each of those. And then in left atrial isomerism or polysplenia, we often don't see a sinus node. Again, if you look when anatomists or cardiac pathologists look at those hearts, they often can identify sort of hypoplastic structures that are inferiorly displaced to where we expect, but are often not producing much of a P wave. From the AV node, the two sort of main subtypes that we think about, asplenia subtype and polysplenia subtype, have differing susceptibilities to different types of AV nodal abnormalities. We associate right atrial isomerism with twin AV nodes, as I was alluding to earlier. And what we mean by that is that there are actually two structures that you can find, sometimes with pacing, sometimes with pathology, and sometimes by studying in the EP lab or in the operating room, where you can see that you can engage a His bundle or notice that there's some conduction that may go through these structures, and that His bundle signal is sort of a marker of an AV node. These can mediate twin node tachycardia, as we saw in that first example, and sometimes they're connected by a conduction sling that can contribute to the abnormalities that we see. And this image is from Dr. Jeremy Moore at UCLA, who compiled a multi-center study of patients who had gone to the lab for twin node tachycardia ablation, and it sort of displays where the different electrophysiologists had seen the nodes located. So you can see that even for it's kind of a dark figure, but even for the anterior or superior nodes, which are the ones that are kind of have the numbers in blue, and the inferior ones are the ones with the numbers in yellow, there's a marked sort of distribution. It's not all like where we found it and where it was thought to be in the EP lab isn't all septal, where we might ordinarily think things to be located. And some of that may have to do with just unbalanced canal and that sort of thing and how it got depicted in the diagram. Clinically, the way that shows up is a couple of different things that you might see in your patients. One is that there may be shifts in the axis just from beat to beat. You may see variability, where here you see that your overall QRS axis shifts pretty dramatically as the tracing goes on. And this is an example from one of my colleagues, Dr. Ed Walsh, who kindly has this beautiful slide where we see, and this is all the same patient, the same leads, that the panel all the way to the left represents conduction mostly down one node. And you can see that there's there's a QS pattern, for example, in lead 1. And if you switch over and look at the panel all the way to the right, you'll see that it's an R wave followed by an S wave, so a totally different pattern of activation. And this is not, sometimes you're reading EKGs and you're like, oh, they put the leads on wrong, and you call down and you say, well, you do it again, but this is for real. And you can see that that shift, and that's a perfect key that for you that this happens. And this patient then went on to have the SVT that was using the first node as its primary driver, as its antegrade driver, and then coming back up the other node. So lots of interesting things that we can see in these patients. And forgive the a little bit not very fancy drawings, but we often the terminology is just sort of very specific here, and sometimes it can be hard to kind of visualize what's happening in twin node tachycardia, and people hear us talk about dual AV node physiology and twin node and how are those different. This upper drawing where it says AVNRT represents just your sort of typical teenager who might have SVT mediated by two pathways within the AV node. So one AV node as normal, but one pathway that's abnormal called the slow pathway, and then one that's the fast pathway, the one that you want. And the reentry happens where you go down the AV node, the slow pathway. You can do it both ways, but most of the time it's down the slow pathway, back up the fast. And when it's the same sort of idea in twin nodal tachycardia, where you go down you use one of the nodes in an antegrade direction, and the other node mediates the conduction in the retrograde. And then where it gets exciting is like that first patient where you can have fast pathways and slow pathways within each of those nodes. And then you can start doing the math as to the permutations of how many different combinations of tachycardia you can get. So there's been data that has shown, as you might expect, that patients with right atrial isomerism are more likely to have twin nodal tachycardia compared to those with left atrial isomerism, just because of the presence of those two nodes. And on the flip side, those with, as we mentioned, with left atrial isomerism are more likely to have congenital AV block. Again, this is from the single center study out of Texas that we mentioned before. So this is a beautiful diagram from Cardiology in the Young in 2006 that has 35 specimens of hearts with heterotaxy, and the authors attempted to group them to kind of get a better sense of, beyond just the level of asplenia or polysplenia, what are the different ways in which these hearts can be connected electrically. And the sort of diagram of the atria and the venous connections are at the top in the pink color, and then you see the green is the various AV nodal patterns that we have below. And you see the circles are the compact nodes that they have, and then there's different branches. So the one is the right bundle, and then the sort of fan that you see. And I've stared at this so many times, trying to get my brain to sort of wrap around all the different patterns and how to group them when I think about patients who I might be sending to the operating room or thinking about going to the operating room. And as much as I try to sort of see all that nuance, I think it's really difficult for us as clinicians with a patient in front of us where we're using the echo and the MRI and the cath ahead of time to even just understand their plumbing, to kind of also overlay the complexity of the conduction system onto it. And just in the interest of time, I'm going to skip through that. But I think that's what informs kind of the next phase of my talk, which is going to be talking about how we've tried to kind of acknowledge all the variation that we see, and then implement the most effective technique in the operating room to try to avoid creating any AV block. Before I move on to that, I'll just quickly say that in our heterotaxy program, we have established for those asymptomatic patients who may not come to you with the symptoms of palpitations or bradycardia associated symptoms, just some sort of baseline suggested testing, including EKG, obviously, and then some longer term monitoring periodically. And I think that has been pretty helpful for us, keeping an eye on kind of what the heart rates are looking like when we might think that we need to intervene from a pacing standpoint, and also to pick up some subclinical changes that might indicate the need for intervention. All right, so luckily Dr. Hoganson has laid a lot of the groundwork for the our center's philosophy on biventricular repair, which we're often pursuing in these patients. This is not from our center, but from another center in a report from 2015, which gathered together 20 heterotaxy patients at this center who underwent biventricular repair. And in this publication, 25% of those patients required a pacemaker afterwards for postoperative complete heart block, which is a pretty shocking number. At our own center, in around the same time period, this publication gathered almost 100 patients, and in that series, 14% of them required a pacemaker. So when we're doing these biventricular repairs. And what this sort of had led us to ask is, if we have all this data and these beautiful pathology studies showing us where this is and ways to predict, why are we still getting heart block? And I think this also goes to, this video goes to what Dr. Hoganson was saying earlier about how it can be hard to visualize where things are. And I give the surgeons all the credit because I don't know how they do it really. But, if you're asking them to kind of, you see that level of detail and intricacy in the diagram and you've got an error, an error bar of a couple millimeters, then you might be in the wrong spot. You really have not a lot of margin to not get the know where the conduction is if you are going to perform these repairs. And I think the other piece is just the knowing how variable these hearts can be, taking a patient-specific approach and not relying on rules or a certain sort of standard or anticipated finding, but really trying to come up with a patient-specific and centered approach to this. And so we started trying to come up with solutions for this about 5 years ago. And it's a group of us from both EP and surgery and from the engineering group supported by Dr. Hoganson and others of his colleagues. And we've worked to establish a pretty rigorous and consistent approach to patients both with heterotaxy and without who are coming for biventricular repair, where we look for the electrical signals in the lab. We use a commercially available catheter. That's not perfect, but does the job a lot of the time and sort of lets us play a game of battleship with the surgeons where we tell them where we see it and what the coordinates are. And then they sort of adjust accordingly to where they're interested in. And you can see that we get a lot of data in a hurry with that catheter, which is a 4x4 grid of electrodes. We see the atrial electrograms, the His bundle electrograms, and ventricular electrograms. I won't give you a test on this. And we're looking for the His. We're looking for that high frequency signal in between the two, the atrium and the ventricle. And so the surgeons mark this catheter because, again, it's used in electroanatomic mapping, that sort of the way that we map in the lab, and we're using it in a open beating heart. They mark that so that we can reference which side it's on, and then we start looking at the signals and feeding back to them where we're seeing evidence of the conduction. Sometimes it's a little noisy, we wait for it to get clean, and then we can pretty rapidly take in that data and be able to help them look at places in the heart, both where conduction is, but also where conduction is not, because that can also be very helpful if you know that you need to put that VSD patch in, and you have conduction at the superior aspect. Perhaps you sort of adjust where that patch goes, and that can allow us to avoid that complication. This is a little bit out of date now, but this has really taken off and is something that pretty much I think it's fair to say that pretty much every patient with heterotaxy who now comes to our center and is having work done near the AV valves or in that region will get mapped. We published the first 150 patients that we mapped in JACC last year. And we were really thrilled to find, this is what we had been seeing clinically, but we're thrilled to find that when we compared them to a matched historical cohort of 200 patients who were unmapped, that we had reduced our center's incidence of heart block with these complex biventricular repairs in patients with heterotaxy specifically from 16% to 2% with mapping. And we've subsequently mapped another 350 or so. We're about at 500 patients that we've mapped. 95 of those patients have had heterotaxy syndrome, and only 3%, which is actually 3 patients, have had the complication of post-op heart block since we've instituted mapping. So it's been incredibly gratifying. It's always sort of a bummer because I don't get to meet the patients because they don't need a pacemaker, and so I don't need to talk to the family. But very happy to have it that way and to intervene on the front side of things rather than being in the operating room putting the pacemaker in with the surgeons afterwards. We look at this data in a lot of different ways, and we're hoping that, I won't go into all this just in the interest of time, but we're hoping that by continuing to gather data, by continuing to map it onto where these beautiful 3D models that Dr. Hoganson's team create, that we're going to continue to advance our understanding of the conduction system in heterotaxy. That beautiful work that we saw was 35 patients. We've already got 95. Each of them has a model that we've labeled over the time that we've been doing this, and we have a digital atlas that lets us enter data that aligns with our patients and then pull up examples of patients that we've mapped who have had similar anatomy and similar findings, so that maybe that will help the surgeons in their planning anticipate, maybe not take the place of doing the mapping itself, but at least anticipate in their thought process or in counseling families where we might find this, so that we have that going into our minds, or in our minds going in. So EP can definitely be a complex aspect of these already complex patients. I would highlight that the anatomy really is variable, and I think a patient-specific approach, whether you're doing that in the EP lab or in the operating room, is really the only way to go. And thank you to Dr. Shidlow for including me in the team. It's really been wonderful to participate, and thanks to all of you.